All righty. Well, welcome everybody. I'm very pleased to get us started this morning or this afternoon for our clinical conversations. We're back for September and start of the academic year. So welcome. I'm Barry Sarvet, and I'm the statewide medical director for McPat. And I would like to welcome everyone to the program. As you know, we do this on the fourth Tuesday. It's our practice to do this on the fourth Tuesday of every month. And the next one is coming up in October 25th, on October 25th. The topic for today is cannabis use disorders in adolescents. And particularly, as you can see on the screen, we're focusing on medical management options, and particularly the utilization of N-acetylcysteine as a tool to help folks with this condition. Before we get into it, just a few housekeeping pieces. First is that as has been our practice since last year, we're offering CMEs, particularly for physicians and nurse practitioners. And we are very thankful to the Mass General Hospital Continuing Ed Department for helping to support this process for us. To get your CME credit, please enroll by sending a text to 857-214-2277 and then put in the code. This for today is KECZES. As you can see, it's highlighted on the slide if you're watching the video. If you have to register for this, if you haven't already done so, if you have, then it'll automatically mark your attendance, and then you have to complete an evaluation in order to get your credit. The session, as always, will be recorded and available on the PAP website. A copy of the PowerPoint slides will also be available on the website as well. If you have questions as we go along, as you know, we call it a clinical conversations because we want to have a conversation. So feel free to enter questions into the chat or the question function on the Zoom. And I will actually read the questions and try to insert them at the best time so that we can kind of not interrupt the flow of the presentation. And some of the questions will be saved for the end. Some might be able to be addressed in the middle. If you wouldn't mind filling out a survey at the end, we'd really appreciate feedback and ideas for future presentations. So the introduction of our speaker, as well as an additional speaker. Jennifer Ross is a pediatrician, and she has a public health degree as well. And she works at the Adolescent Substance Use and Addiction Program at Boston Children's. She is our speaker, and she attended medical school at University of Cincinnati, and also got her MPH degree there with a concentration in health services management. She did her pediatric residency at the Children's Hospital of the King's Daughters in Norfolk, Virginia, as well as a medical toxicology fellowship at the University of Virginia and a fellowship in pediatric addiction medicine at Boston Children's. Currently, she provides care for adolescents with a range of substance use disorders, from new onset problems to severe use disorders and addiction. I'm also pleased to introduce Maria Alden. Maria Alden is an LICSW clinical social worker, and she actually is a person who you may speak to actually as you go along in your practice. That she works for our ASAP arm of the McPat program, and she's involved in helping you guys sort out clinical questions for kids who present with substance use disorders and things like that. So I will now turn it over to Jennifer for our presentation. And thank you, Jennifer.
Oh, thank you for that kind introduction. And thank you all for having me, and for Maria for joining today. So today we will cover the effects of cannabis on the adolescent brain and discuss screening for substance use disorders in this specific population. And then we'll conclude with a discussion on the use of N-acetylcysteine or NAC in the treatment of cannabis use disorders. So to start, just about what cannabis does to the adolescent brain so we can understand why it's so important to intervene and provide treatment for these patients. So many years ago, it was believed that brain development was complete by age 10. So this was originally thought because studies that have been done measuring brain weights found that the average brain weighed 3 pounds. So during development, the brain reaches this adult size of 3 pounds around the age of 10 to 12 years. And the assumption was made that if the brain weighs the same as an adult brain, development must be completed. But of course, as we developed better ways of studying the brain, we were able to learn more about, neuron growth and brain development. And it became apparent that obviously the brain is not finished developing by the age of 10. So this is a picture of how neurons look before blossoming, which we'll talk about on the next slide. But after birth, neurons begin to rapidly sprout these connections, these synapses with each other. And the connections between cells form these complex circuits of on and off neurons that work together as a unit. And this is the first stage of development. It's called blossoming. So the enormous number of synapses allows for flexibility and improving the function, making them more efficient as a circuit. And they're nearly limitless connections that these can make, right? They're ideal for learning, but they're not as good for proficiency. An example that is often associated with this is the ability of a young child to learn languages really easily. They can pick up words really quickly, but they're not able to speak the language as proficiently as an adult would. So synaptic pruning, that's the second stage of our development. And that's where these redundant connections are kind of pruned away and they leave these fewer connections, but they're faster and set the stage for learning proficiency and skills. This, refinement, quote, of circuits relies on this balance of these interactions between neurons. So this is really important to understand because this stage of development is crucial. It's where outside influences like alcohol, like cannabis, other substances can act directly on the brain chemistry and really disrupt that balance and really play a detrimental role in development. And then finally is our myelination. That's our third and our final stage of development. And this is the stage where these axons are wrapped in this fatty tissue, right? They become insulated. And this really increases the speed at which the signals can travel along the axon. And it's an important stage in brain development. It happens at the end of our development, and it's really not easily reversed. So it kind of makes permanent all the changes that have happened up until this point. And it's important that the healthy and functional connections form in the brain before we have this myelination that solidifies what's left. So we now know that myelination and therefore our brain maturation, it's not complete until probably the mid-20s. This slide shows a 3D reconstructed MRI image of the human brain across different ages, starting from age 5 there on the left to age 20 on the far right. And these scans show that as we get older, the gray matter volumes typically decrease due to synaptic refinement or to pruning, and the white matter volumes typically increase due to our myelination. So that green coloring there shows the gray matter in the brain, representing what's unmyelinated. And then as it turns more blue, as you can see, it's taken over by white matter or myelinated neurons. So you can see myelination continues to occur throughout adolescence into our 20s, where that back of the brain really develops first, and then the front and sides of the brain become myelinated later on. So we can correlate our developmental milestones with what we know about brain maturation. So the cerebellum develops first, it's at the back of the brain, and it's associated with our toddler milestones, our balance, our walking, our coordination. And then we move forward to the amygdala, that's in your temporal lobe there. And it's associated with emotional regulation, right? So registers whether something feels pleasurable or painful. And then the temporal lobe kind of continues to develop rapidly during middle childhood and adolescence. And this includes the nucleus accumbens, which is part of the reward system And it controls our desire to engage in activities that we find rewarding. And then finally, as we move all the way to the front of the brain, we get to the prefrontal cortex, which matures last and is associated with our executive functioning and our impulse control. So why is this important? This is a chart comparing what we just talked about, right? Our brain maturation between the nucleus accumbens and the prefrontal cortex. And, as we mentioned, that nucleus accumbens, the reward center, develops first before the prefrontal cortex can. And since the prefrontal area is responsible for impulse control, that means that in adolescence, there's this imbalance between a mature nucleus accumbens, which is seeking out rewards, and an immature prefrontal cortex, which would be our executive functioning and controlling of impulses. So this image shows us the reward pathway in the brain. The nucleus accumbens is located in the striatum right next to that septum of the limbic system, and it produces GABA, which sends output to the prefrontal cortex. So the ventral tegmental area, that VTA, provides input to the nucleus accumbens via dopaminergic neurons. And it's that dopaminergic input from the VTA that causes this major increase in dopamine levels in the nucleus accumbens. And if you compare that to, where substances of misuse have been shown to increase dopamine levels, that also occurs in the nucleus accumbens. So the yellow dots on this image indicate where different substances of addiction or misuse have effects on neurotransmission, which they vary in a little bit, but they all cause that nucleus accumbens to have this flood of dopamine. And these substances create this bigger dopamine release than would be seen otherwise in day-to-day activities. So they're causing a bigger reward sensation, especially when used in adolescence. So this slide shows an experiment. This is where cues were just given on a screen, and the respondent had to remember which side of the screen they were on. And participants were guaranteed money for participating, but they could earn more money based on how accurate they were. And the lines show the brain signals in the imaging. So on the left chart, the gray shaded area is where a small reward was given. And adolescents, which are shown by that black line, actually deactivated their reward center when presented with small awards. So you can see that the younger children and the adults both were a positive when given a small reward, but the adolescents actually deactivated, which is contrary to on the right, where you look, the arrow shows that when given a large reward, adolescents had this huge reward center response, much bigger than younger children or adults. So the study's kind of showing that substances that may produce this big neurochemical reward, right, like we talked about, could have this higher addictive potential in the adolescent brain than we might see in the adult brain. And of course, this is especially dangerous because the adolescent brain is still in the process of developing. So we use these pictures of plots of land when we're talking to adolescents in our clinic to show that, the house under construction, which is comparable to the adolescent brain, is going to be the most vulnerable to environmental damage. So this is the same, true of brain structures that are actively undergoing development. They're going to be most vulnerable to our exogenous substances. And it's been shown that a younger age of alcohol use, we know, increases the risk of developing an alcohol use disorder. The same is true for cannabis. Among those who started to use cannabis at age 19 or later, there were fewer people who developed a use disorder or an addiction. The risk here in this study dropped from 17% who started cannabis at age 13 all the way down to 4% if you waited until you were over 21. So just to quickly review the term cannabis, it refers to all products derived from the plant Cannabis sativa. Cannabis is the botanical name of a genus within the Cannabaceae family, and this genus actually includes 3 species. So there's Cannabis sativa, Cannabis ruderalis, and Cannabis indica. But the 3 species now actually they interbreed, and the species boundaries are pretty fluid. So it's actually been suggested that only a single species, the Cannabis sativa, be recognized. Cannabinoid is a compound that acts on the endogenous cannabinoid receptors, so in the body. So cannabinoids can be categorized into one of 3 groups. There's endocannabinoids, phytocannabinoids, and then synthetic cannabinoids. So endocannabinoids are formed in either the human body or in other animals, And they're natural molecules produced by the body that work on this receptor system. So they help regulate coordinated body movements and memory and our perception of pleasure and time. Phytocannabinoids are derived directly from the cannabis plant. So they're molecular chemical compounds that bind to receptors, and they can kind of mimic the human neurotransmitters that are present in our body. And then there's synthetic cannabinoids, of course, that are synthesized in the lab. So synthetic cannabinoids are usually actually full agonists of the cannabinoid receptor, which means they're really potent. So they create both these more intoxicating effects and more clinical side effects. These three categories are important to differentiate just because different medications and different products utilize very different versions of cannabinoids, but they all have this idea of working on our endogenous cannabinoid system. So first discovered back in 1992, it was found out that our brain actually produces its own endocannabinoids, right? That's why we have this cannabinoid system. It was a naturally occurring metabolite in the human body that was found to activate cannabinoid receptor 1. And it was named anandamide, which actually comes from the Sanskrit word for bliss. So essentially, comparing structures there, THC and anandamide have some similarities, which is why THC can fool the brain by binding to the same receptors that anandamide usually would. Anandamide, of course, is part of our own endocannabinoid system along with the receptors. And in recent years, there's been a tremendous amount of research really to understand what all the effects are of the endocannabinoid system in our brain. This is another slide that we show our adolescents to explain why the brain responds to cannabis in general. So we explain the brain has its own system. It acts like the brain cell's volume control dial. So if a volume or signal coming from one neuron gets too loud, the receiving neuron kind of says, whoa, and sends anandamide back through the synapse to turn that volume down. So the brain's own endocannabinoid system regulates how active neurons are and how much neurotransmitter gets released. So these are neurotransmitters that do all sorts of tasks. They affect pleasure and mood and pain and appetite and motivation, and they include a bunch of different things like dopamine and serotonin and endorphins. So overall, this endocannabinoid system is helping keep brain cell activity in balance. So it's not underactive like we've seen associated with depression or ADHD, or overactive as we've seen in epilepsy or PTSD. And it turns out there are a lot of cannabinoid receptors. They're one of the most common types of receptors in the brain. So there's two main types of these receptors. There's CB1 receptors, which are located primarily in the brain. They're also found in blood vessels and heart cells. And then there's CB2 receptors, which are located outside of the brain in the peripheral nervous system and glands. This slide shows where the receptor sites found as those pink dots you're seeing have been found in the brain. So they're plentiful in so many areas of the brain. If you relate back to our picture before, it's the prefrontal cortex with your executive functioning. They're in the cerebellum there, affecting coordination. They're in our visual area, the reward system, the hippocampus, affecting memory. I mean, they're all throughout the brain, and they're affecting so much of our regulations and emotions and sensory information, such as pain. So how does THC compare to anandamide, and THC technically called delta-9-THC? THC and anandamide both dial down neuron activity, so they're both changing the amount of neurotransmitters that are released. But when THC binds to the cannabinoid receptor, it's much stronger, and it has a longer effect on brain cell activity than our natural molecule, than anandamide. So we say THC's effect is like a sledgehammer, right, compared to a precision scalpel of anandamide. And by occupying those cannabinoid receptors, THC interferes with anandamide's ability to naturally protect and balance cell activity. So when you're repeatedly exposed to THC, your brain starts to adapt. And as mentioned before, there's this balance of inhibition and excitation of neuron activity that's important for your proper brain functioning. So THC changes the level of neurotransmitters in the brain, and the brain cells that get overstimulated by these effects start to compensate by scaling back down the number of receptors. So that's why we start seeing tolerance after repeated use. And then repeated THC exposure continually dampens down the activity, and then there's too much inhibition. And then in response, the brain tries to compensate by making some cells more excitable, And when someone who regularly uses cannabis doesn't use it, the inhibitory effect of THC isn't there, which leaves the brains too excited. And that's why we see cannabis withdrawal symptoms. These symptoms can include a variety of things when you're in withdrawal: restlessness, anxiety, increased sensitivity or reactivity, just difficulty with sleep, falling, staying asleep. And these withdrawal symptoms probably won't be as dramatic as what we see for other substance use disorders, such as alcohol or opiates or benzos. But people in cannabis withdrawal do report substantial distress over these symptoms, particularly with the difficulty sleeping, which can make it really difficult to quit. And then there are risks associated with use, which we'll discuss a little more, but there's immediate risks, impaired driving. There's effects that are seen quickly, such as poor school performance, or, if you have severe cycles of nausea and emesis. And then there's these longer term effects we're seeing, such as psychosis and depression and anxiety and addiction, right? Cannabis use disorders. And then we all know about vaping induced lung injury. And then additionally, use in pregnancy, right, is associated with a lower birth weight. Or if there's a chance that another kid or a child in the home or elsewhere could get a hold of these and become intoxicated as well. And then just to reiterate, as mentioned on the previous slide, these are some of the long-term effects associated with cannabis use specifically that started in adolescence. So there's psychoses, depression, anxiety, just really feeling dissatisfied with your achievements, and then a cognitive decline and addiction. So just as in the case with alcohol, the hippocampus is particularly sensitive to cannabis use. The hippocampus is one of the few areas in the brain where new brain cells are generated throughout our lives. So one well-known effect of cannabis use is memory impairment. And scientists have found that THC dampens down the activity of hippocampal neurons below the level that's needed to trigger formation of a memory. So with chronic THC exposure, and therefore continual suppression of hippocampal neuron activity, the neurons start to lose these connections to other neurons, which makes it harder and harder to form and retrieve new memories. We all tend to lose neurons in the hippocampus as we age, which explains why we have a harder time remembering and learning things as we get older, but chronic THC exposure will speed up this process. And then many studies use brain imaging to compare the brains of those with cannabis use and those without. But these findings can be limited by showing results only at a specific point in time. So often we can't determine whether the differences found were caused by the cannabis use or if they were already present before people, participants started using cannabis. So this paper was published in the Proceedings of the National Academy of Sciences, and it describes the results of a prospective study that examined the effects of cannabis use on cognitive performance over many years, over decades, actually. So referred to as the Dunedin study. It was conducted in New Zealand. It followed almost 1,000 participants from age 3 years to 38 years. And at age 13, this was before the vast majority had started to use cannabis. At that point, I think only 7 participants had tried it. All of the participants completed a comprehensive neuropsych assessment battery. It included an IQ test, an executive functioning and memory and processing speed. And then they completed this again when they were 38 years old. And cannabis use information was collected at multiple assessment time points. And the authors were able to determine how cannabis use affected neuropsych performance by comparing the change in individual scores related to the different levels of cannabis use. So this is what they found. The chart shows the change in IQ scores as correlated to years of heavy cannabis use. So a positive number, like at the bottom, represents an increase in IQ scores, while a negative number indicates a decrease. And the authors report that there's a significant relationship between years of cannabis use and change in IQ scores between age 13 and 38, especially when you compare to the almost no change in IQ seen for participants who never used cannabis. So you can see by the average IQ change, those who never used cannabis had a score of 99.8 at 13 years, and then a score of 100.6 at 38 years. But those who had significant cannabis use, which was marked as at 3 of the 5 assessment time points, those with significant use had an IQ drop of nearly 6 points, from 99.7 to 93.9. And they found this same pattern even after they controlled for numerous other confounding factors like alcohol use, nicotine use, mental illness, years of education, all of it, the significant association remained. There's also an association between cannabis use and psychosis. So a meta-analysis of 6 studies found an increased risk of psychotic outcomes among those who had used cannabis more frequently compared with those who didn't use cannabis. And the frequency in these varied of cannabis use from a history of 50 times to daily or weekly, but nearly all of them showed this significant association. So this data is just from, our team at Boston Children's. There was a survey of 500 adolescents who were just coming in for routine primary care. And about a third of them reported past year cannabis use. And of those third, more than 1 in 4 had reported hallucinations, and 1 in 3 reported paranoia or anxiety while they'd been using cannabis. So putting these together, more than 4 in 10 had experienced a psychotic symptom while using cannabis. And just as a reminder, these were healthy adolescents just presenting for their routine care. And the experiences they reported occurred while they were using cannabis and then cleared. So none of them had a diagnosis or a psychotic disorder, but it's concerning to think how frequently these adolescents were experiencing these symptoms, and probably not a great leap to think that for some of these kids, these symptoms might have been a warning of the toxicity of the cannabis on their central nervous system. So this slide shows the results of a study using MRI scans of the corpus callosum. That's the bundle of fibers that kind of connects the 2 brain hemispheres, allowing the 2 sides to communicate and work together in a coordinated way. So these were young adult males who smoked cannabis daily and started at an average age of about 15 years. And then they were scanned along with age-matched adolescents who didn't use cannabis. And the different regions of the corpus callosum fibers are shown there in the bright colors on the 2 scans. You can see the scan on the right of the adolescent with daily use shows a thinner corpus callosum fibers than the scan on the left. So this is showing there are kind of these white matter integrity issues for the adolescents with frequent cannabis use. So poor communication across different parts of the brain, the ones that need to work together for proper cognitive function, might be one of the causes of why cognitive disorders are associated with cannabis use, such as schizophrenia. And this study was just a study of a correlation between those reporting frequent history of cannabis use, categorized here as more than 50 times ever, and an association for schizoaffective disorder. So again, this association remained even after adjusting for factors like use of other substances, socioeconomic status, IQ, or other disorders. This was a systematic review of studies with the goal of assessing whether cannabis can cause mental health effects that persist beyond the acute intoxication associated with recent use. And their overall conclusion was that cannabis increases your risk of psychotic outcomes independently of the acute intoxication effects, meaning that just cannabis use in general is associated with development of mental health issues later in life. And then just a final point on the dangers of cannabis use. This is a point I try to make in all of our visits with our patients, that there's an association between cannabis and the impaired ability to drive. So when researchers tested people's performance during acute THC intoxication, they found that THC impaired your attention, it impaired your working memory, and you had slower coordination and reaction time. And there's actually been even more recent studies that have showed impaired reaction time lasts longer than the effects of acute intoxication, meaning that you might not feel the euphoria or the euphoric effects of cannabis, but you might still be unsafe to drive. So this is why in our clinic, we have strict recommendations about not driving if a patient has any positive drug tests, since we don't fully understand the impact of simply having cannabis in the system, but know that it likely continues to impair reaction times and coordination. So moving on to kind of discussing the screening process for substance use disorders in adolescents and young adults. So from a survey of adolescents reporting to the Children's Adolescent Clinic, 3 in 10 reported past year cannabis use, and then half of those, about 1.5 in 10, reported using cannabis regularly, at least monthly, if not more. So this chart is from the 2020 results of Monitoring the Future study. That's the long-term epidemiologic study that surveys trends in legal and illicit drug use among American adolescents and adults, and then also kind of surveys their perceived levels of risk and their disapproval or approval. It's conducted by the University of Michigan and funded by NIDA, and it's been going since 1975. And as this chart shows, in 2020, 30% of 8th, 10th, and 12th graders reported ever using cannabis. So it's important to identify substance use, and in particular, substance use disorders, as part of routine primary care. As common as these, problems may be, clinical instincts aren't really sensitive for identifying them. This is a slide showing work done by Boston Children's. And in the study, adolescents presenting for primary care were recruited to participate where they had a psychodiagnostic interview for substance use disorders while they were waiting to see their clinician. Then the clinician after the visit was asked to report if the patient had used substances, and if so, if they had a substance use problem or disorder. And as you can see, the sensitivity for identifying substance use was about 63%, which is actually pretty good. But if you look at the sensitivity for identifying a problem or disorder, it falls to 14% or below. And obviously, these are not good numbers for a typical screening test. So thankfully, we're seeing that pediatricians' self-reported screening rates using a validated tool are increasing. On the left and right are results of a national survey conducted by the AAP, in which fewer than half of all respondents said they screened adolescents for substances at least annually back in 1997. Thankfully, there's been a tremendous trend toward increased screening over the next decade. And by 2008, more than 87% of respondents, this was in Massachusetts, said they screened at least annually. That number actually kept increasing, and then all the way up to 2017. That was actually when only a single respondent did not indicate that they annually screened. So all physicians who interact with adolescents and young adults should screen, right, patients for substance use disorders. One available screening tool that can be easily used in the primary care setting is the Screening to Brief Intervention, or the S2BI. And this screening tool categorizes substance use disorder risk in adolescents by asking about frequency of substance use. So it can be employed by physicians to aid in kind of this quick identification of adolescents who could benefit from further intervention. Since, we talked about how provider impressions have a low sensitivity and underestimate substance use in adolescents during routine well-child checks, we need these validated screening tools. And it's important to remember that these tools need to be used in the way they were, studied and indicated, and hopefully in an anonymous way where a parent or caregiver can't see the results or complete them for the adolescent. We'll keep talking about the MCPAP site, but for anyone looking for resources on screening for substance use disorders, you can go to the MCPAP website, hover over the providers tab on the top bar, and it'll bring up this bottom screen. You can click on screening and toolkits, and then it'll take you to this new page, which has numerous resources you can download, which includes the S2BI workbook, the quick guide, and the postcard. So on this slide, this is the actual, S2BI tool. It was developed by Dr. Levy at Boston Children's a number of years ago, and it uses the STONE question: in the past year, how many times have you used X? And has a response item for nicotine, for alcohol, and for cannabis. And then if the adolescent reports any past year use to any of those 3 substances, the tool continues to ask about 4 other classes of substances, such as prescription drugs, illegal drugs, inhalants, and synthetic drugs. So the goal of this screening is really to use the responses to triage adolescents into 4 actionable risk categories. Monthly use kind of correlates with your mild or moderate substance use disorder, and then greater than monthly use would correlate more with your severe substance use disorder. So in the first study of this screening tool, this included participants recruited both from primary care settings and from outpatient substance use treatment programs. And the S2BI was found to have a high sensitivity and specificity for identifying both substance use and substance use disorders. And then more recently, it was retested with 500 adolescents presenting for primary care without this augmented group of teens from the substance use program. And the results were similar. Though it was found that at the recommended cut points, the sensitivity was much better for moderate or severe substance use disorders than for mild substance use disorders. And this was true for both alcohol and cannabis use disorder. So once an adolescent's identified as being at risk for, a substance use disorder or having one, what's the next step? So this is a diagram, from the AAP, and it talks about the substance use screening, brief intervention, and referral to treatment or SBIRT recommendations. And you can see it's divided into different recommendations based on risk stratification of use. So any adolescent identified as having a use disorder is recommended to receive a brief intervention and then likely referral to further treatment. And there's policy statements that the AAP puts out through their Committee on Substance Use. But this slide really reiterates the overall message of their recommendations. The non-use message should be reinforced by pediatricians through clear and consistent information. So in other words, the AAP encourages healthcare providers to take every opportunity to recommend non-use as really the best strategy for protecting adolescent health and development. So when you determine that, a brief intervention or referral to treatment is needed, or if you need advice or have questions, the best thing to do is reach out to your MCPAC team and ask for an adolescent medicine consult. Someone from ASAP is on call every weekday during business hours for MCPAP. And we'll talk about this again with Maria at the end, but, please reach out. We're happy to call you back and discuss the plan specific for each patient, whether it's guidance for management in your primary care setting, connecting them to substance use counseling, or potentially referring to our program. So just so you have that support available. So I really, in this slide, is just trying to elucidate the gap between brief intervention and rehabilitation programs, right? In real life, there are very few places in which teens can access all of the things that come in the middle, even though that's probably what the vast majority of them need. There's medications and counseling modalities, but in actual practice, only a small percentage of teens have access. And so if we're ever to kind of widen this access, we have to put these services in place where they can get to them, right? So primary care is an obvious first choice. And really brief intervention is just the tip of the iceberg in terms of primary care management. So this slide gives examples of other strategies we can use in primary care to help address adolescent substance use. These strategies include advice to parents or education or medication to treat withdrawal symptoms, reduce cravings, laboratory testing, right, urine drug testing, and just good follow-up with providers that these patients really trust and feel connected to. I always want to raise the point that, as we know, substance use disorder is one of the most stigmatized conditions. Not only is the patient stigmatized, but the disease and the treatment. And when working with these patients, terminology really matters. This study was just one where healthcare providers were presented with two case vignettes that were identical, with one referring to a patient as a substance abuser and one referring to the person as a patient with a substance use disorder. And healthcare providers were kind of prompted to make treatment recommendations. And those in the substance abuser group often talked about, morality issues or law enforcement, and those in the substance use disorder group were more likely to recommend therapeutic services or mental health care. And the conclusion just, of course, being that even among highly trained professionals, exposure to these two commonly used terms evoked largely different judgments. So we really encourage you not to use the word abuse. Not only is it stigmatizing, but it's actually outdated. The DSM-5 no longer uses the term substance abuse in any way. And then just a little more about terminology. There's numerous phrases we hear that are stigmatizing. Anything that puts the onus on the person, addict, abuser, dirty. It's so important that we as healthcare providers use medically accurate terminology and our non-stigmatizing words. So making a commitment to change the language we use to describe the patient, the disease, the treatment itself. A lot of it just comes down to labeling, right? And avoiding terms like alcoholic or user, instead using our person first language. And then just referring to tests by their medically accurate results, right? Positive or negative instead of clean or dirty. And just remembering that, substance use disorder is a disorder, it's a disease, and referring to it as such in front of the patient. And then, a big thing as we talk about medications next, I don't typically use the term medication assisted treatment because medications a lot of times are the treatment, right? So just calling them that, medication, treatment, pharmacotherapy, and making sure they know that this is a treatment for a disease. I know there are parts of the recovery community that embrace labeling, such as, in AA, where they're encouraged to say alcoholic, but patients kind of have their own agency to see how they view themselves. And I encourage you to continue to use destigmatizing language. So finally, talking about our, utilization of NAC in the treatment of adolescents and young adults. So N-acetylcysteine, or NAC, it's available without a prescription, and it's really promoted as a dietary supplement. It's been shown to reduce cannabis cravings in adolescents in 2 separate trials, which we'll talk about. The findings haven't been replicated in adults, so there isn't an FDA indication for NAC in cannabis use disorders. But nonetheless, in our practice, we use NAC frequently for adolescents who are having difficulty quitting cannabis use. And anecdotally, we feel it's been helpful for many of our patients. So NAC's been used for many indications for many years. It comes in numerous different forms. It's oral, it's IV, it's inhalational, and it does have FDA-approved indications, specifically the treatment of acetaminophen overdose, either orally or IV. And then the inhaled form is used in a variety of treatment of pulmonary conditions. It's also being studied in lots of other indications, and it's pretty commonly used off-label. Some of the more common ones being obsessive compulsive disorder, repetitive self-excoriation, or the prevention of contrast-induced nephropathy. So we don't understand all of the mechanisms of NAC, but we know it's a precursor to the amino acid cysteine, and then it leads to more glutathione synthesis. And then from its FDA-approved indications, we know it protects the liver, such as in, acetaminophen overdose. It's anti-inflammatory, and then it's mucolytic when inhaled. It's also believed to impact glutamate in the brain, specifically via upregulation of one of the glutamate transporters that's found in the nucleus accumbens and in the prefrontal cortex, which are, of course, are parts of our brain involved in reward pathways and executive functioning. So because of this theory, NAC is being studied in the treatment of substance use disorders, not just in cannabis use, but also in cocaine use and nicotine use, other stimulant use, as well as in bipolar disorder and schizophrenia and depression, and a variety of different indications. So this was the original study. It's a randomized controlled trial. It was conducted with adolescents using cannabis. It lasted for 8 weeks, and it compared treatment with NAC versus placebo on the odds of a negative weekly urine cannabinoid drug test. So these adolescents and young adults were aged 15 to 21. And in that population, it showed that a NAC dosing regimen of 1,200 milligrams twice daily resulted in significantly increased odds of having that negative urine drug test for cannabis. It was interesting, the same group actually did another study that was very similar, conducted in adults aged 18 to 50 years. It was 12 weeks, but another double-blind randomized placebo-controlled trial. And it compared treatment with NAC and placebo again. And in the adult population overall, there was not a significant difference in cannabis abstinence between the 2 groups. But if you broke the groups out, it wasn't statistically significant, but the subgroup of participants aged 18 to 21 who are receiving NAC actually had numerically doubled rates of abstinence compared to placebo. So clinically, the results from that second study actually supported the use of NAC in the adolescents and young adult age range. So because of the data from these 2 studies, we offer NAC to patients in our clinic with cannabis use disorders. The dosing regimen is 2,400 milligrams daily. We divide it into 2 doses as it was studied, 1,200 milligrams in the morning and in the evening. And overall, it's really well tolerated. Patients rarely report side effects. It's infrequent, but the most common would be nausea and vomiting. So if a patient has known gastrointestinal sensitivity, we'll start them at a single dose of the 600 milligrams daily and kind of titrate up to that full dose as is tolerated.
Hey, Dr. Ross.
Yes.
Just a quick question. One of the attendees asked if you have any information about the socioeconomic and racial background of the subjects in the study that you just presented.
I don't know that. That is a great question, but I can send out the actual data from it and look to see what besides the age groups, I don't know if I am familiar with the rest of the characteristics of the study participants, but that's a good question.
Thank you.
I can include a link in the chat after to that study in full. so we can read it in more detail. So just how to get NAC, it comes over the counter, but it can also be prescribed. So prescriptions aren't always going to be covered by insurance. It's generally impossible to know if insurance will cover it for an individual patient until they try to pick it up at the pharmacy. But over-the-counter NAC is a supplement, so as such, it's not regulated by the FDA. The over-the-counter NAC also comes in just a huge variety of doses, and it can be formulated by many companies with other ingredients, with other minerals, selenium, molybdenum, those are some common ones, or milk thistle. And so because of this, we always recommend prescribing it so we can guarantee patients are getting the right thing. If a patient chooses to buy NAC over the counter, we always, encourage them to make sure nothing else has been added, no other minerals or, supplement materials, and then to recheck each bottle every time in case the manufacturer changes the product. So these are some pictures. There's a multitude of different versions of NAC. Even in these pictures, there's doses from 295 milligrams to 1200 milligrams, everything in between. And this can be really confusing for patients. So again, we recommend prescribing it whenever possible. And then the most common complaint we get about NAC is that it smells bad or has an unpleasant odor or taste. It has a sulfur component, and so it can smell very unpleasant. So we often provide kind of some recommendations to aid with taking NAC or convincing adolescents to take it. Taking it with something that tastes strong, chocolate syrup, eating something fatty first, like margarine or butter, that'll kind of help block the taste receptors. Also, refrigerating it has sometimes helped to reduce the odor. And then sometimes capsules instead of tablets can have a better taste. There's also a question we get sometimes about if there are supposed to be spots in the coloring of the NAC, and that's actually due to oxidation if it's kept in the humidity. So it's best to keep the pills in a dry environment if possible. So really, that's all my information. I'm happy to take more questions on NAC, but just to summarize, the adolescent brain is so predisposed to damage from cannabis use. And we kind of talked about all these short-term, long-term effects that are associated. And any physician who really interacts with this population should screen. And then as part of that screening, recognize when further interventions needed, which can include NAC. And most of all, of course, please reach out to us, which we're going to talk about the process now with any questions, any consults. We're happy to help in any way we can. So the way to do this is, of course, to call your MICPAP team, ask for a substance use consultation. And then we also want to review this option of ASAP MICPAP counseling. So I can hand it over to Maria to share information about that.
Dr. Russ, a moment before we do that, there's a question from the audience about how long the duration of administration or treatment with NAC is recommended.
Yeah, no, it was just studied, unfortunately, for the, the 2 times for the 8 weeks and the 12 weeks. So we start there and then usually just see how the adolescent is doing. If they still feel like they're having cravings, if they're able to, have abstained from cannabis, if they're continuing to use it anyway, we continue treatment. But if they're able to abstain, you can either wean it off, right? We can do the kind of titrate down after that time, or you can stop it, and it's usually tolerated very well.
Thank you. Another question, this is actually from me. I was curious about your experience as far as the subjective kind of perspective from patients taking NAC. In your experience, have you found that it reduces cravings? Does it decrease compulsiveness in a way? I wondered about that, just given its use with OCD. But do you have anything to say about sort of what the impact or what the effect of that particular supplement is subjectively for patients?
Yes, we definitely have a subgroup of patients who say it didn't do anything, but we have quite a number who say usually cravings is the word they use, that they have decreased cravings, that they feel like they're not, thinking about it as much. And I'm sure there is some placebo component to it, that we have a treatment available and it's something for them to do that is working, but it seems to very, subjectively also help with cravings is usually the word they say. I haven't heard specifically the word compulsion used as much, but you're right, it is interesting in that it's being studied for all those other indications as well.
Interesting. Thank you very much. So Maria, welcome, and thanks for joining us for the discussion. Did you want to make any comments at this point, or should we wait for some questions and things?
I was just gonna briefly just share that I'm Maria Alden. I am a clinical social worker who works with the ASAP MCPAP counseling program, which is a virtual substance use counseling. The program has grown in the last 2 years. Another clinician, Lori Gates, who's also a licensed independent clinical social worker. We provide individual substance use counseling, comprehensive substance use evaluations, as well as parent guidance. And we've also added, I've run one group and hoping to start another group in our program. And what we do is the referrals come through the MCPAP line. So you would speak with the ASAP consultant. And we work with pediatricians as well. So we do, the kind of assessment, make recommendations based on those assessments. And then we will kind of support the patients and where they're at, trying to evaluate, are they ready to reduce their use? Are they considering it? And then as well as working with their families. And so we often will reach out to the pediatricians to collaborate in their care and to support support them. So, looking at clinical drug testing, maybe exploring NAC, nicotine replacement therapy, all these things, we can do that support. In one of Jennifer's slides, she had talked about like behavioral contracting and, things that's part of the brief intervention. And we can, support physicians in that, because I think it can be overwhelming sometimes when you have patients who are using substances and families that are very anxious and worried about that. So kind of always reach out, never hesitate to reach out to the ASAP team through MCPAP, because they can, recommend counseling as, part of their recommendation when they speak with you, and we can, collaborate and work as a team. So just kind of a reminder that, it's that, we have openings, that we can provide support to your patients and the families as well.
Thank you so much, Maria. So why don't we see if there's more questions. Right now, there are no outstanding questions in the chat or the question box, but feel free to type something in, or even if you want to just type in that you want to be unmuted, and we can unmute you for you to ask your own question.
And I will say, in the paper, they have some more demographics about it. It looks like the majority were male and white, enrolled in school, and also smoked cigarettes is what they provide as the baseline.
In the absence of other questions, I thought I would ask both of you actually about harm reduction, for teenagers with cannabis use disorder or cannabis use. Do you have any thoughts about that? I think that, we generally, sort of emphasize, and try to focus on abstinence just because of all the harms of cannabis, especially in the developing brain. And I think you summarized that area of research really well. But the reality is, that not everyone's listening to us. And I'm wondering, what kinds of harm reduction approaches are being considered these days?
I think one of the, the best tools we have are our urine drug screens. We use a quantitative number, and so that adolescents are actually able to see the amount of cannabis in their system. And so then we can use those levels to set goals, like let's try to get it down to this number or this number. And so even if they would otherwise be having positive results, this gives them a goal to work towards in that setting of harm reduction, that they're using less and able to get reinforcement for that.
Thank you. Maria, do you have any thoughts as well?
Let's say, in the counseling relationship with adolescents and young adults, I make it clear that my recommendation is abstinence. But obviously as a clinician, I'm working with them to kind of explore the reasons behind their use. What is it that they're hoping to gain? Is it alleviating anxiety? Is it, because it's social, like feeling socially awkward or not wanting to be left out? And my goal in that is kind of coming from a non-judgmental place and working over time and with our relationship, kind of pointing out things that, may not be aligned with their own values of things that are important to them, like, wanting to be successful, wanting to go to college, wanting to, be healthy, kind of helping point that out in kind of a non-threatening way. And also just kind of, helping, because a lot of times over time, they do kind of identify things that aren't going well with their use. That's what the importance with the counseling relationship is. And then I think on the other side of it, working with parents, a lot of times it's working with them on behavior management and kind of looking at, well, what's going to motivate this teenager to stop using? And I say, learner's permit driving is a huge motivator. And I think because of, independence is so important to adolescents. So a lot of times, it's working on like, don't allow them to get the permit until they show you some improvement in their, with the urine drug screens. So that's, kind of looking at it as far as what's important to the adolescent and how we can do that. And so that's why it's a collaborative relationship.
Very nice. Very nice.
Barry, it's John. Maria, I have a question. You mentioned parents, and I think parents are often frustrated because they may know their kids are using, but the kids are not yet ready to get help. And I believe that you've had some situations where you have got a referral just for the parents to talk to them about how they may manage the situation. And I just wonder if you would detail that a bit more.
Yeah, so sometimes I will get referrals, for a particular patient. Our program coordinator will outreach to the family and they'll say, oh, this kid is not going to go to another therapist. They're totally unwilling, but I need some support and I need some help on how to handle this. And so, if the child is under the age of 18, we can provide parent guidance sessions without having a release signed by the adolescent, because I'm not sharing any information with them. And it's usually, a lot of it is working with the parents. Sometimes it's, just, support, providing resources, but also on how to address some of these behaviors. If the child is over the age of 18, they need to actually consent, sign a release of information for the parent to speak with me, because of, with insurance and billing, because it's billing under their name. But anyways, it can be really helpful. I mean, sometimes I've even just, supported parents while they're trying to figure out, residential programs and that type of thing. I think a lot of it is a process. And so, yes, if you have really overwhelmed parents, don't hesitate to reach out to the MCPEP line and speak to one of the ASAP consultants, because they, that is something that is there and available.
Very nice. Great question too. So I do not see any other questions. Oh, looks like there might be one more in the chat. Oh, no, that was just your link to the article. Okay. Well, thank you so much, you guys. This has been really, really interesting and stimulating, and really nice to know, more about the emerging sort of evidence about medication treatment, not medication-assisted treatment, medication treatment for substance use disorders. And this has been really nice. So thank you so much for joining us and talking with us, to our speakers, and thanks to the audience for participating and for being here with us. And we'll see you next month.
Thank you for having us.
Thank you.
Take care.